afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on antimicrobial stewardship in primary care, audit and feedback to improve antibiotic prescribing. My name is Valerie Leung, and I'm the ASP lead at Public Health Ontario, and I have the pleasure of moderating today's session. At this time, I'd like to do a land acknowledgement for Toronto, where I'm situated today. We acknowledge the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Before we start, I'm going to mention a few housekeeping items. First, the chat pod has been disabled to limit any distractions during the presentation. However, please use the question and answer pod if you have any questions during the session, and then we'll be answering them at the end. Our speakers and moderator will make every effort to address as many questions as possible. If at any point during this session you experience technical issues, please email capacitybuilding@oahpp.ca. I would also like to share that as the moderator of this session, I do not have any conflicts of interest. It is now my pleasure to introduce today's speaker, Dr. Kevin Schwartz. Dr. Kevin Schwartz is the Division Head for Infectious Diseases at St. Joseph Health Centre in Toronto and Co-Medical Director for Antimicrobial Stewardship at Unity Health Toronto. He is an academic infection control and antimicrobial stewardship physician at Public Health Ontario, an assistant professor at the Dalla Lana School of Public Health at the University of Toronto, and an adjunct scientist at ICES. His clinical area of interest is adult and pediatric infectious diseases and tropical medicine, and his research interests include vaccine preventable diseases and antimicrobial stewardship, with a particular focus on improving community antibiotic use to slow the emergence of drug-resistant infections. And now I'm going to pass it along to Kevin to begin.
Thank you, Val. And it's a pleasure to be here talking to you guys about antimicrobial stewardship and audit and feedback, and going to have a lot of local data and context for everyone today. So I also don't have any conflicts to disclose. So the objectives for this talk are to identify the important public health threat that is antimicrobial resistance. I'm going to describe the risks of antibiotic overuse and what that means for antimicrobial resistance, interpret recent data on the effectiveness of antibiotic audit and feedback in primary care, and I'm going to end with discussing the implications for incorporating antibiotic audit and feedback into our AMR action plans and antimicrobial stewardship broadly. So to start off, that antimicrobial resistance is a pretty important problem. And this is a nice description, I think, by the World Health Organization, that AMR is a slow tsunami that threatens to undo a century of medical progress. And it's really, the way I like to explain it, it's much beyond being able to treat, common or even, severe everyday infections, but it really will jeopardize half a century of medical progress that we've made, from looking after more premature babies, organ transplantation, advances in cancer chemotherapy and cancer care. If we're unable to effectively treat the most common complications for these, which are bacterial infections, a lot of these procedures will become more riskier and more difficult to undertake. So it really threatens a lot of what we have, I think, come accustomed to in modern healthcare. AMR is currently a pretty big deal globally, where a really nice sort of review that was published just a couple years ago now, that this group estimated about almost 5 million deaths that were associated with bacterial antimicrobial resistance. And they also tried to estimate the amount of those deaths that were directly attributable to the resistance. And they estimate there's 1.27 million deaths globally attributable to bacterial resistance. And just to put that in context with other common conditions and causes of mortality globally, that actually bacterial AMR is a more common cause of death than compared to HIV, as well as breast cancer and malaria globally. In Canada, this was a nice report that tried to estimate both the clinical and economic impacts that we have locally from antimicrobial resistance. So currently about 26% of infections are resistant to first-line antimicrobials, and that's projected to increase to 40% by 2050 in the absence of significant intervention. In economic terms, if we get to that 40% level, that would be a GDP decline of $388 billion. And to put it in Ontario numbers, there's an estimated 6 deaths every day attributable to bacterial antimicrobial resistance currently in Ontario. So I'm going to talk about antibiotic prescribing and what we are seeing currently in Ontario. This is a study that our group did a few years back where we wanted to try and estimate what's going on in primary care and how much room we have to move and potentially decrease. So this is a study we did on using electronic medical records from Canadian primary care practices. And just to highlight that about 25% of antibiotic prescriptions were likely unnecessary. These tier 2C and tier 3 conditions are really conditions where antibiotics are either never needed or rarely needed. And so most of these are likely unnecessary. Also to highlight that, from this study using a combination of administrative data codes and medical records, a lot of antibiotic prescriptions could not be adjudicated. Either they were not associated with any sort of relevant code or they weren't associated with any visit at all. And so it's hard to adjudicate those, but conservatively, we could reduce probably by 25% in primary care. It's another study I wanted to highlight where we compared the total antibiotic use to the unnecessary use. And so just to highlight a couple things from this graph. So on the x-axis is the total antibiotic prescribing rate, and on the y-axis is the proportion of total antibiotics that are unnecessary. And the size of these circles are how busy these doctors are. And so a couple things to point out, that the more antibiotics doctors are prescribing per visit is strongly associated with the chances of those antibiotics being unnecessary. And we also show that, the busier doctors are, again, the more likely they are to prescribe more antibiotics and to prescribe more unnecessary antibiotics. And those associations, I think, are important for our sort of strategy and also what we use as metrics later on to try and give docs feedback on their antibiotic prescribing and how we want things to change. We also prescribe antibiotics for too long, and we've done some work related to this as well. So just to highlight the table on the right, this is a table of summary of a number of trials that we've provided as part of our feedback to docs to share the data with them about appropriate antibiotic durations. I mean, the bottom line is that most infections that are being treated in primary care can be treated with 7 days of antibiotics or less. And there's now over 130 different trials across over 20 conditions, mostly showing that shorter courses of antibiotics are non-inferior to our sort of traditional or arbitrarily more prolonged courses, which are often 10 to 14 days. The figure on the left shows results from a study that we did in Ontario. Each dot is a physician. And basically what we're showing is on the x-axis, these are typically antibiotics for urinary infections, and the y-axis, typically antibiotics for respiratory infections. And these are the proportion of these doctors' prescriptions that are for greater than 8 days, which again, we sort of conservatively defined as prolonged in this study. So we see, first of all, lots of variability. And when we looked at the models for what was predicting prolonged duration prescribing, the biggest predictor we saw was actually the career stage of the physician. So doctors that have been in practice for 25 years of age or more, and there are a lot of these outliers on the far right side of the graph, was driving more prolonged duration prescribing, which is probably something that shouldn't be, and we sort of flagged as an area where we could probably see some improvements. So I'm just going to make the case very briefly that antibiotic use is directly related to antimicrobial resistance. And I have the one slide in it, but there's actually hundreds of studies that show this. There's a couple nice systematic reviews. So the first one by Costello is a summary of individual levels. So individuals that receive antibiotics, when they pooled these studies, they were 2.5 times more likely to have an identified antimicrobial resistant organism later on. There are over 200 studies at the population level that show relationships between community or area geographical antibiotic use and rising antimicrobial resistance, and again over 2 times the risk, based on different exposures at the neighborhood or community geographic level of antibiotic use. I just sort of highlight the study that was published after this Bell systematic review, but it's a really nicely done study that looked at neighborhood fluoroquinolone antibiotic use through different neighborhoods in Israel, as well as fluoroquinolone resistant E. coli. And they looked at this both at the individual level and at the population level, whereas they excluded any patient that actually got fluoroquinolones. And you see really nice gradient effects for the more antibiotics that are used in the neighborhood, the more likely we are to find resistant organisms in both the individual patients, but also patients that were never exposed to that antibiotic. So there's a very clear, well-described relationship between the amount of antibiotics that we use and the amount of resistance we are going to see. This is a study that we did recently in Ontario that's not published yet, but I just wanted to highlight, we took advantage of this a cohort of COVID-19 patients that we had in Ontario and all the antibiotic data that we had with them, just to try and estimate what proportion of resistance can we attribute to the antibiotics that they received. And in general, most of these patients, the antibiotics they received were not necessary, because generally antibiotics were not necessary for COVID, and bacterial secondary infections were overall uncommon in the overall population. And basically what we were able to estimate is that 17% of the patients that got antibiotics, their AMR was attributable, 70% of them attributable to the antibiotics they received. When we look at the whole population, so everyone with COVID-19 in Ontario that was 65 or older, whether or not they got antibiotics, 4% of the AMR that we could see with our microbiology data set was directly attributable to the antibiotic prescriptions that were given to patients with COVID-19. So, it may seem relatively small, but on a population level, it's pretty substantial contributor to antimicrobial resistance. And so why does this matter? So we did this umbrella review where we took advantage of the 71 randomized trials that looked at antibiotic prescribing duration. So was longer duration equivalent to shorter duration? And the vast majority of studies found non-inferior outcomes was what the goal of these trials were. But what we did is we pooled the data that the trials reported on antibiotic side effects or adverse events, and just were able to estimate that for each additional day of antibiotics that were given to patients in these randomized trials, there was overall a 4% increase odds of having antibiotic-associated adverse events. And we can see that we estimate whether you're giving 5 versus 3 days or 7 versus 3 days, you start to see like pretty large increases in side effects that patients are getting from antibiotics. So, and these are conditions where generally it doesn't make any impact on the clinical outcomes in these trials, but now we're seeing signals for harms from antibiotics with each additional day. Because I would say that it's actually complicated. I would say that there are probably a large part of all of those organizations that people said that all 4 are responsible would actually not necessarily agree that it's their responsibility. But I would say it probably varies by area and organization and country as well. And so the CDC, I think, put out a nice statement on core elements for outpatient antibiotic stewardship. But the US sort of landscape is a bit tricky. And I think a lot of this is intended to fall on sort of these groups of clinics or practices, sometimes affiliated with a hospital, or sometimes sort of like its large sort of organization in itself. I would say in Canada, the landscape is pretty different. have a lot of sort of solo practitioners, urgent care, walk-in clinics that operate on their own, groups of practices or groups of physicians that work together, maybe affiliated with a hospital, but it's a bit, it's quite variable. And I would say there's no one group or organization that really accepts responsibility for how we do this. And so what drives overprescribing? I think this was a nice literature review done that tried to synthesize all of this qualitative work about what drives overprescribing. The bottom line is that it's actually pretty complicated, and there's multiple factors that vary, by encounter and by physician and patient, but there's a whole bunch of external factors, time constraints, organizational pressures, not having access to data to kind of see how you're doing. There's a lot of prescriber factors. I've listed a few of them here. So for instance, experience and training, but habit is a really common one. Anxiety or fear, worry that patients are going to get worse. And you just sort of want to be on the safer side, that kind of mentality. Diagnostic uncertainty is often cited, where you think it's this, but you're not sure. And that also influences the decision making. There's a bunch of patient factors as well, sort of perceived expectations from the patient, language, communication barriers, socioeconomic status. So there's lots of different factors that contribute to antibiotic prescribing and overprescribing. And the way that we approach it, we really need to think about what we're trying to change along this spectrum and how we're going to change it. So audit and feedback is one sort of interesting thing that we've adopted to try and modify antibiotic prescribing behavior. And just as like a background, audit and feedback basically just means measuring an individual's professional practice, and then we compare it to some sort of standard or benchmark, and we feed that back to the physician. There was a systematic review that was done by Noah Ivers over 10 years ago now, basically showing that audit and feedback is effective to modify professional practice with a pretty wide range in terms of how effective it can be, and often varies by the different ways that it's implemented. And this review is currently being updated. So in 2018, we decided to do a trial where we would mail letters out to physicians. We used a data set that we had at the time that was a pretty high level, just has overall antibiotic prescription counts. And essentially, we gave personalized letters, but sent this to the 3,500 physicians that were the highest antibiotic prescribing doctors in Ontario, and just let them know that they were in this blue part here. They're part of the 25% of physicians that have prescribed 65% of antibiotics. And we gave them some tools and resources to try and improve prescribing. And we partnered with the OMA group of family physicians, as well as Choosing Wisely Canada, to deliver this intervention. We did do a randomized trial with this as well, where all we did was randomize. We had a control group that got no letter. Then we had physicians that got a letter. And then within the physicians that got a letter, we randomized the third page of the letter to either these Choosing Wisely sort of guidance on appropriate antibiotic initiation, or we sent them this letter on appropriate antibiotic durations. But they didn't get both. They got one or the other in this intervention. And just to highlight the results, the intervention overall was effective. In particular, the duration letter, we saw improvements in both antibiotic initiation by about 5% and reduced duration of reduced prolonged antibiotic prescriptions by about 8% as well. And so on absolute numbers, we estimate that if we sent the duration letter to the highest antibiotic prescribing physicians in Ontario, we would reduce antibiotic prescriptions by 147,000. We would reduce prolonged duration prescriptions by 84,000 in the province, and we would save about $2.7 million in just the cost of the drugs alone. That doesn't include any sort of downstream potential economic impacts of less antibiotic side effects and less AMR or less C. diff or any of these other downstream impacts. That's just the cost of the drug. So an incredibly cost-saving intervention we estimated from this previous trial. So since then, since we did that, the landscape in Ontario, just so everyone is on the same page, has changed a little bit. So what used to be called Health Quality Ontario is now called Ontario Health Quality, puts out my practice reports that physicians can voluntarily sign up for and receive electronically. And the My Practice reports have a number of different indicators, but in about 2021, they added an antibiotic indicator into those reports. So docs can volunteer for these reports, and they can log in and then see their antibiotic prescribing data using our administrative data from ICS that uses the Ontario Drug Benefit. And as part of this work, which we had started pre-COVID, that we were planning to do a trial, and so what we ended up doing in collaboration with Ontario Health is we did another mailed letter trial to the docs that have not already signed up for their reports, and to see if we can improve audit and feedback in some ways. And the kind of rationale, leading into how we designed the intervention was around a couple of different things. And thinking back to that, image I showed you about like the different ways that we, overprescribe antibiotics or what drives it. So one of them was related to why docs often don't respond to audit and feedback, or what they say they're concerned about, or why they not want to engage with it as much, is that they say my patients are different, that the data hasn't properly captured my patient complexity and patient differences. The other one, another example of, that we think drives antibiotic overprescribing is sort of this imbalance of risks, that doctors tend to underestimate the harms of antibiotics and the side effects and overestimate the benefits, right? So it's more of that, they're concerned that they don't want the patient to get worse, and maybe there's minimal harm to antibiotics, so I'm just going to give the antibiotic prescription. When in fact, for many of these patients, obviously it's the reverse, that they're now more likely to have harms from the antibiotics than benefits if it's a condition where they're unlikely to benefit from. So this idea that they just prescribe antibiotics to be safe. So here's how we set up our trial. So there's around 15,000 family physicians in Ontario, but a lot of those, several thousand of those physicians are not active, and so we excluded those that either didn't see any patients, or those that don't see enough patients that are 65 or older, or don't prescribe enough antibiotics, at least some minimum amount of antibiotics, to be useful for the data. The Ontario Drug Benefit in Ontario is limited to complete information on patients that are 65 and older, so the feedback that we give physicians is limited to that age group. So there are about 9,000 active family physicians in Ontario, and then we excluded, of those that signed up for the Ontario Health reports, which left around 6,500 docs. And then of those we were able to link and have a valid address, we sent them opportunity to opt out. And then we opted out about 350 docs that either wrote back that they didn't want to receive the intervention, or that they didn't have a valid address, or we have a return to sender, which left just over 5,000 docs that were randomized. And then they were randomized in a 4-to-1 ratio to either receive no letter or any further communication until after the trial was done, or to get the intervention. Within the intervention group, we embedded a 2-by-2 factorial trial, which tests these different components of the intervention, which I'll show you on the next slide, but also has an efficiency component for the evaluation. So just to show you what the intervention looked like, so this is the first page of the letter for the doctors randomized to the adjusted feedback letter. And what we did was that we took all of their patient and practice characteristics, so the amount of patients they see, age, sex, socioeconomic status, the patient comorbidities, the practice setting, whether it's in the emergency room or not, and we incorporated all those variables into a hierarchical regression model. We then outputted standardized antibiotic rates that are adjusted for all of those factors. And we sort of tried to highlight that throughout several components of the letter, that their data is adjusted, they're compared to peers that are very similar to theirs because we adjusted for all of these factors. The doctors that got the unadjusted data didn't have any of that stuff or that language in the letter. They just got their antibiotic data, antibiotic prescriptions per 1,000 patient visits, and they're told that they're compared to all the other Ontario family physicians, not specifically compared to similar peers. So that's the adjusted factor. The harms messaging factor was on page 2 of the letter, where we randomized docs to get either this infographic on the risks of harms, such as antibiotics, the 30% risk of antibiotic side effects, the increasing resistance and mortality associated resistance, and other language just about the importance of antimicrobial resistance and antibiotic harms. The docs that were randomized to the non-harms messaging basically just got an infographic about the lack of benefits with antibiotic prescribing for most respiratory infections and didn't get any of that harms messaging. So this is the intervention that we did in, this would have been in 2022, early 2022. So the rest of the letter, everyone else who got the letter got the same information. So they got this table on antibiotic durations, which I showed before, and this is based on our previous trial showing this to be effective. We also added giving them their data with no peer comparison, but just that they got the percentage of their antibiotic prescriptions that are greater than 7 days. With that, most of them can be less than 7 days. We gave them some evidence-based communication tips about how to talk to patients about appropriate antibiotic prescribing. And we gave them some Choosing Wisely Canada resources and links to resources like the viral prescription pad to help incorporate into their practice. Interventions co-signed by Ontario's Chief Medical Officer of Health, by the Ontario College of Family Physicians, and by Choosing Wisely Canada. So just to show you the results, these will be published hopefully quite soon. But this goes back all the way back to 2019. So just to highlight a couple of things, I mean, we saw huge decreases in antibiotic prescribing during the pandemic, as most people know. And then we did our intervention in early 2022 as respiratory infections and antibiotic prescribing was starting to increase. So the green line is the docs that got the letter, and the red line are the docs that did not. And you can start to see separation at the intervention there throughout 2022. And these are the main results. And so the primary outcome was overall antibiotic prescribing rate between the intervention and control group. And we saw a significant, about 5% relative reduction in the antibiotic prescribing rate. We looked at a number of other outcomes as well. So where we could specifically evaluate if we thought the prescription was likely unnecessary, associated with viral prescription code, there was actually an 11% significant reduction in antibiotic prescribing for that outcome. Prolonged duration prescribing, again, significantly reduced. We had a 15% reduction for that. And we also saw about a 6% reduction in broad spectrum antibiotic prescribing, which we didn't specifically intervene on in this intervention, but it goes along with the overall reduction. For the factorial trial component embedded within the intervention was actually a bit interesting, is that we didn't see any significant further improvements or reductions in antibiotic prescribing by the changes that we made to the intervention. Interestingly, we saw actually small, about 1%, but statistically significant increase in antibiotic prescribing for the docs that got the adjusted feedback metric compared to the unadjusted one. And we saw no significant differences in the harms messaging. We did a bunch of stratified analyses as well in this trial, where we looked at the intervention effect by a number of different factors for the primary outcome. I just wanted to highlight a couple of these. So the one on the bottom, by baseline antibiotic prescribing, it was statistically significantly different that the high antibiotic prescribers were more likely to respond to the feedback report, which is really what we wanted to see. As I showed you before, these are the docs that prescribe the most antibiotics, the most room to move, the most unnecessary prescribing, and this is what we wanted to see the most. Also highlight that we actually found no significant difference by neighborhood income quintile of the physician's practice. And we hope that this is going to be a intervention that can help improve the inequities that we see in antibiotic prescribing. So that was nice to see as well with this. We did some fidelity assessment. So we wanted to see if docs were actually opening the letter and how many received to them. So we made up to 2 phone calls for a random list of 135 physicians after the whole intervention completed and they received their debrief letter. It was very hard to reach actually physicians. So more than half we could not reach despite 2 attempts. About 30% we did reach and they did not receive the intervention or did not know what we were talking about. And we could only confirm about 13% of docs actually received and opened the intervention. So I would say like the effects that we're seeing are actually like despite this pretty low engagement. So a few limitations just to highlight. So we implemented this during COVID and antibiotics were rising and it was a bit of an unusual time, but important thing that we added the control group that we could compare, things during the same time period. We excluded MDs that are already interested in feedback and have voluntarily signed up, but I think these results are really generalizable to an unengaged group of physicians for audit and feedback. The factorial analysis, I think, needs a bit of caution. We weren't specifically powered or designed for that. It was powered for the intervention versus control, and there could be some contamination between arms as possible as well. We did not evaluate the safety of antibiotic reduction in this study, but overall it was a small reduction, and likely what we're seeing is reductions in the unnecessary prescriptions, and I think it's much less likely docs are prescribing less for conditions they really feel are necessary. These data are limited to patients that are 65 and older. That's what we have the data for in Ontario. I did want to show this. This is, we have not published yet, but what we did in, this is Dr. Sakib is a postdoctoral fellow working with us, but we have another data set from IQVIA, which has all antibiotic use. We just don't have all of the other data and visit data and other components. But the top line is what we found in the trial. And what we did was we took the same cohort of physicians, which we could match them, and then we reanalyzed the trial with this different data set, which we have in all of these different age groups. And just to show that overall, the intervention is impactful. And it's not that physicians receive this data and only make differences to their antibiotic prescribing to older patients, but it looks like it actually applies to children and other age groups as well. So we did find significant reductions antibiotic prescribing across all age and sex groups, which I think is really reassuring for how we're doing this in the limitations of the data that we have. So this just summarizes that trial that I just mentioned. Wasn't going to go through this again, but significant reductions in different aspects of antibiotic prescribing by this mailed audit and feedback letter. So I mentioned, the low engagement, which I think is really an important thing to look at in the future, how we can improve that. The factorial part was overall unsuccessful or even potentially harmful from the adjusted data. And I don't know the answer to that. We have some qualitative work to try and explore this. Was the adjusted data and the modeling like too complex and it didn't achieve our goals? I think one interesting thought, did it paradoxically reinforce the cognitive bias we were trying to address? Did it remind docs that their patients are different? And instead of actually reversing, oh, okay, they've accounted for it, maybe they still didn't believe the adjustment and actually were just more likely to have that bias that my patients are different. I shouldn't respond to this, which was kind of, an interesting theory. I don't know the answer. The harms messaging, I also don't know. We thought this might have an impact, but perhaps the way that we did it was not like new or provocative enough to the physicians to make an impact. And again, something we're going to explore further. So I want to switch gears a little bit. I'm going to just share the results from another study that we've recently finished. This is a systematic review and meta-analysis of trials of antibiotic audit and feedback in primary care. And this was part of the larger Cochrane review on audit and feedback that I mentioned earlier. And basically what we did is that we leveraged that and took off the trials that were related to this specific topic. And so, as part of that screening, it was almost 5,000 articles that were identified. But basically, we were able to leverage the screening work that had happened and pull out the antibiotic relevant articles. Then we supplemented it from an additional search specifically related to antibiotic audit and feedback. And then we added in a few extras from reference reviews to get 49 trials that are specifically related to antibiotic audit and feedback. So what we then did is that we separated the trials by the outcomes. So 42 of these trials were compared to a control group that got no audit and feedback. And then a lot of them look at multiple or sometimes just different outcomes, whether they looked at total antibiotic prescribing or specifically unnecessary prescribing, prolonged duration, or a whole bunch of trials just looked at the selection of antibiotic. Could they make that more appropriate or guideline adherent? And so these are the trials that just specifically looked at total prescribing volume as an outcome. And you can see, like, from the individual trials, there's a whole bunch of negative trials and variable effect sizes. But when we meta-analyze these, there's a significant 11% reduction in overall antibiotic prescribing. For the inappropriate initiation outcome, there was a 23% reduction for once we meta-analyze all the trials. A few trials looked at prolonged duration. Again, a significant reduction. We got 9% overall reduction for duration, and for selection, 16% for the trials that specifically looked at sort of broad spectrum or appropriate antibiotic selection. We also stratified these trials by a bunch of different criteria. I would say the messaging from this is that it seems like the intervention is pretty effective across different different types of interventions that were done. I highlight a couple of things there, that it seems like the studies that were able to give the intervention more frequently, where they were given more than quarterly, that seems to be more effective than giving it less frequently. There's a little signal for more effect size in countries that have baseline higher antibiotic use. Again, it's a little bit sort of just one cutoff there, but it does seem like it's more likely that it would have an impact where jurisdictions have more room to move. And you wouldn't expect as big of an impact when antibiotic prescribing is already pretty good. So just to summarize, significant reductions across, these different outcomes from our systematic review and meta-analysis. I think the conclusion is that we have probably better data for this, or a better high quality data for antibiotic audit and feedback in primary care than I would say like most quality improvement initiatives that we do. I would say most things are not supported by this much high quality randomized data, and really antibiotic prescribing feedback should be a routine quality improvement expectation, I would say, for all primary care prescribers. And this is what I hope that we're going to be, working towards based on the, summary and quality of the data that's out there. So I think there's a couple things, looking forward. I think we're really interested to study how we can improve audit and feedback. Overall, we have small reductions, but I think the holy grail here is, can we improve engagement? And I think there's a number of interesting things we can sort of explore and study to see how we can do this. Co-interventions, I think, are key. I think audit and feedback likely has a ceiling effect. I would describe as a pretty passive intervention, although it's effective, and we need other things to complement it if we're going to overall continue to improve and maintain good antibiotic prescribing. And then finally, how can we integrate this into policy and make this more widespread? So I just want to talk about a few co-interventions that I think are really kind of neat and interesting and probably should be integrated or at least studied further. So one example is the Do Bugs Need Drugs program. And I would say the West Coast provinces in Canada do a much better job at this than we do here in Ontario. The Do Bugs Need Drugs program has really been around for a lot of years now and has patient-facing and clinician-facing resources and presence, and sort of and in BC, they've been really doing this for I think almost 20 years now, and really have a comprehensive program designed to improve community antibiotic prescribing through their Antibiotic Wise .ca website and program. And it, and I think it shows. So this is federal data from pre-COVID. Everything got a little messy to interpret in COVID, but it's not surprising that BC has consistently the lowest antibiotic prescribing across Canada. And it, and it's not related to really differences about BC, and patients are not being undertreated for infections, but they have this nice, robust, thorough program that's been active for many years, and I think it shows in this data. I will just point out that our Newfoundland colleagues dispute the accuracy of this data, and they've actually done some work that show that this is not totally accurate. So I'll put that caveat in as well. So public communications, I think, is an interesting, and we don't do this currently in Ontario. This was a systematic review done to look at evidence from public communications campaigns. They weren't able to meta-analyze this data because these studies are not able to be grouped together. But there was about 75 million participants overall across all these studies. A lot of them are large geographical areas, and the bottom line is that there's a range of 14 to 30% reduction in antibiotic use for respiratory tract infections when jurisdictions initiated some sort of public targeted communications campaign about appropriate antibiotic prescribing. We had submitted a grant in Ontario to try and do a trial for something along this lines. That unfortunately was not successful this last round, but something that we hope to do in Ontario, and I think would be a benefit. Biomarker testing is also another area that has a fair amount of evidence, and people have been interested in. This was a Cochrane review, was recently updated, that has 13 trials. Most of them are in CRP, C-reactive protein, point of care tests for, to help with antibiotic decision making. A quarter of all the people were in children. And overall, I mean, CRP testing at point of care was effective at reducing antibiotic use. They report a 23% reduction in antibiotic use. In the trials that looked at it, there was no difference in symptom alleviation or mortality or outcomes that might be suggestive of undertreatment. So this is something that can be, incorporated and probably does work. I would say the cost effectiveness analysis is inconclusive at this stage. There's a nice summary of it, and some studies do show cost effectiveness. It probably is very highly dependent on how it's implemented. And if this gets used a lot in patients where, for instance, they wouldn't have prescribed antibiotics anyways, or they would have prescribed antibiotics anyways, it's hard to show cost effectiveness from this, compared to the cost of the drug and maybe some other downstream impacts. But if it's implemented well with supports really targeted to that like gray zone where it's really going to help the physicians in their decision, or just sort of nudge them over the edge where they probably already think they should need to go, this can be a piece of stewardship programs. Yeah, so I want to spend the last few minutes just talking about policy. So as many people probably aware, the Pan-Canadian Action Plan came out this year, which sort of highlights what we need to be doing as a country to try and address AMR. And there's several sort of pillars within this. And one of these is stewardship. We're trying to do some work that really fits into this stewardship pillar to try and address AMR. We have a small grant from CIHR for a project that's called CAMBuild AMR, which is meant to try and bring together the different provinces and territories for either improving or initiating or escalating the way that we're doing antibiotic audit and feedback in primary care across the country. I mean, as most people know, like Canada is really 13 separate countries when it comes to healthcare, and sort of resources and data and everything is different by province and territory. And what we're trying to do is leverage the previous work that we've done, sort of expertise across the country to support each other and optimizing the way that we can give audit feedback and then improve some antibiotic use. So this is a project that's just getting started now, and we hope to continue it over the next couple of years. We also had an international funded grant that is just coming to an end through JPI AMR, where we had over 30 experts across 11 countries who are really interested in this topic all come together to try and further this field. We had this group did that systematic review meta-analysis that I showed you before, and we also did a modified Delphi process to come up with best practice guidance. And so that's this here where we had 13 best practice recommendations to go out to the field based on sort of the communal expertise and the literature about how best to do antibiotic audit and feedback. There's examples of, positive and negative trials. And I think a lot of it comes down to the implementation, how you're doing it, how you're delivering the intervention, how you're designing it, and hopefully this helps the field improve that. So the last couple things I just wanted to talk about were, related to, knowledge mobilization and how we get this out there in terms of, promoting this evidence and promoting uptake across like the different important stakeholders. One of the things that we are doing is creating policy briefs. And we actually have like another grant that's going to be all about, part of it is really just all about knowledge translation, where we want to create internationally different policy briefs to direct to different countries and international bodies that can influence policy to try and increase the uptake of the way that we do antibiotic audit and feedback. We really want this to be like an opt-out approach. We want this to not be voluntary. We think as part of people that fund healthcare and patients that access healthcare and doctors that work in this should really be routine. Being able to collect data, being able to feed back data to physicians to try and optimize care over time and improve the quality of care really should be standard. And with the amount of evidence that we have for antibiotics, we really feel like this should be routine. We just, in Ontario, we're planning for a World Antimicrobial Resistance Awareness Week activity. For those that don't know, every year, November 18th to 24th, regardless of what day of the week it falls on, is World AMR Awareness Week. And we have activities every year in Canada and globally to promote this. And this coming year, we hope to do antibiotic audit and feedback in collaboration with Ontario Health and the Ministry of Health to promote appropriate antibiotic prescribing and give all primary care doctors their antibiotic data feedback, and to mail them that letter to draw their attention to it and hopefully increase the engagement through both the mailed and electronic reports. I just want to sort of end on the importance of partnerships for this. Like we did a lot of work to try and engage the right people and partners. We really tried to work hard to not do audit and feedback to family doctors, but this is meant to be in collaboration to family doctors. Nobody comes into work as a physician like not doing their best or thinking they're going to prescribe unnecessary antibiotics. Like this is not how like medical practice works. And we've really worked hard to like try and design this intervention with that in mind. Family doctors are underpaid and overworked and have many different priorities. And it's understandable that antibiotic prescribing is not the #1 priority. Antimicrobial resistance also feels slightly distant than a lot of their other priorities. Really, the goal of this is just to be minimally invasive, to do the work on our end, to use the data that we have to support family practice and draw attention to what we think is an important issue in terms of antibiotic overuse and antimicrobial resistance, and antibiotic side effects as well. And so we've tried hard to do that, and I think we will continue to try harder to do that. And I think it's an important message for others that are trying to develop programs about the importance of those partnerships. So just to summarize, AMR is a public health threat. It is causing morbidity and mortality and economic loss for Canadians. Most antibiotics are prescribed in primary care, and about a quarter are unnecessary, contributing to rising AMR. Prescriber audit and feedback with peer comparison is effective at reducing antibiotic prescribing in primary care and is almost certainly cost saving, and we'll have more data on that hopefully in the near future. Antimicrobial stewardship is about improving quality of care, really should be multifaceted, include audit and feedback and co-interventions, and does require, diverse stakeholders and a lot of engagement. I probably have not included everybody, but as for the work that I showed you, I mean, there are a lot of organizations and partners that are involved in this work, and so just want to say thank you to them, and sorry for everybody that I missed, and that I'm happy to take some questions.
Thank you so much, Kevin, for a great presentation. We will now move on to the Q&A segment of the event to address some of the questions from our audience. Please continue to enter any questions you have if you haven't already done so, but I'll just start going through some of the themes that I see. So Kevin, the first question I want to ask is really about sustainability and whether you're planning on monitoring whether these changes are going to be sustained, or you think it might actually just drift back up to previous levels, or do we need to be doing this at a certain interval? So just your thoughts on that.
Yeah, no, super important question. So I would actually say I didn't show it from our previous trial, but actually we split up the data by quarter. And when you look at it by quarter, you already see it shrinking back to the baseline. And so if we're not doing these interventions repeatedly, absolutely, we can expect antibiotic the gains or the changes we make in antibiotics trying to go back to what they were before. So however the intervention is done, it does need to be done repeatedly. It's logistically infeasible, and we don't even have the data update to support something like monthly feedback, which I showed you comes out in the meta-analysis. But this does need to be done semi-regularly, whether it's quarterly, every 6 months, or once a year. I think will have an impact, but it is really important to be done repeatedly.
Thank you. Another question about the trial that came in is this idea of, so you talked about patient characteristics being something that people ask about and all that, and differences when really it still is the same. What are your thoughts about patient volume or patient visit volume and the impact of that? You mentioned, physicians can be really busy. So what are your thoughts about patient volume on the impact of prescribing antibiotics?
Yeah. So, I mean, the first trial that I showed you, we didn't have that. So we just gave them the total prescriptions. And as you can imagine, the most common feedback we got is that I'm just a busy physician, which is true, right? But what we tried to emphasize is that the busier physician you are, the more likely you are to prescribe antibiotics, and then the more opportunity there is for improvement. In the most recent trial in the data, we are already adjusting it for patient visits. So even the unadjusted letter, it's antibiotic prescriptions per 1,000 patient visits. So the data is adjusted for their volume. And so the busier physician doesn't necessarily mean that they are prescribing more antibiotics. Often what we get is just like physician practices vary greatly, right? Where they work more in a merge or more in an urgent care center or more psychiatry or chronic care. And so there's some of that explains the variability. But again, the docs that prescribe the most, like we've shown, still have the most room to improve. So even if the comparator is not exact, it does give them, I think, something to think about and to target. And that's what we're showing that small reduction is demonstrating.
Thank you. And now we've received quite a few questions about going beyond just physicians.
Yeah.
So I think the first thing that a few people were asking about is, now that other clinicians like pharmacists in particular and nurses can prescribe, what are your feelings about, how that might impact AMR? Do you think it's going to be a negative impact or better?
Yeah, this is a good question. So, I mean, I would say the first thing, I think it's really important to include the other prescribers in our stewardship sort of work and audit and feedback. BC, for instance, is doing feedback to dentists, and so they are initiating that work. We are working on that in Ontario. The limitation is data related, that we're not able to link the prescribers like pharmacists, dentists, nurse practitioners with our administrative data, the same that we are physicians, but we are working towards creating the infrastructure where we actually will be able to identify at least some of those prescribers. For dentists prescribe about 10% of antibiotics in Ontario, and over time that's been slowly increasing and not decreasing like we've seen in other aspects, like from family physicians. In terms of what this is going to do overall for antibiotic prescribing, I think it depends about different prescribers. I think nurse practitioners, like physicians and other prescribers, are going to benefit from supports as that increases. And I think it's really important to think about that. And same for pharmacists. I think as pharmacists prescribe antibiotics, we need to think about doing it we need to do it thoughtfully about like what gap we're trying to fill and what supports pharmacists have to make sure the antibiotic prescribing are appropriate and that those resources are created and available to them. And, overall, I think the way we're doing it in Ontario has been so far quite thoughtful. I think pharmacists are really good at following guidelines. And if we can create good guidelines that are available to them, I'm overall optimistic that it could actually improve antibiotic prescribing in Ontario. But it's something that we'll certainly evaluate.
Thank you. Sort of shifting gears a little bit. So one of the issues not really explored in these trials is this idea of diagnostic stewardship. And, what are we giving the antibiotic for? There's uncertainty about that. How do we promote that correct diagnosis? And how does that factor into some of the work that you've done?
Yeah, it's a good question. I would say that the vast majority of instances in primary care, I would say, are that lead to unnecessary antibiotics are not diagnostic challenges. There's definitely some that are, but in general, a lot of it is those other factors that I alluded to. So I would say most doctors have the skills, to basically diagnose the viral versus bacterial infection, especially with an in-person assessment, and sometimes some diagnostic capabilities, for instance, like access to chest x-ray or throat swabs as some examples. So I would say that's the majority of the case. So a lot of this can be done without needing new diagnostics. I think there's potentially a role for biomarkers to try and help differentiate that. I had a slide which got dropped by accident, but it was about multiplex viral pathogen testing for antimicrobial stewardship in primary care. And in general, it does not seem to reduce antibiotic prescribing. And so that's, I think, an expensive sort of way to do stewardship that's likely going to have less impact than these other ways of doing stewardship, at least in primary care for the vast majority of conditions. Now, there may be subgroups, for instance, like kids with pneumonia and emerge, where there certainly could be a role for this sort of testing. But I think for overall in primary care, there's probably limited role, at least from a stewardship standpoint.
Thank you so much. So just looking at the time, we're going to wrap up at this point. I want to thank you so much, Kevin, for your presentation. And I also would like to thank all the audience that joined us today for this webinar. After this, you can expect to receive a brief and anonymous PHO round survey for today's session. Please try to complete this, as this will help us improve our programming. And lastly, to access past PHO presentations and to view confirmed and upcoming sessions, please visit our website, head to the Education and Events section, and click on Presentations. Thank you and have a wonderful day.